Welcome to our debate. Our topics of debate are telehealth therapies versus in-home therapies. A brief description of each topic. Telehealth is the use of medical information exchanged from one site to another via electronic communication to improve the patient's clinical health status. There are two types. There's synchronous live, which involves a real-time interaction between the participants at two or more sites, and then there's asynchronous, which is recording information at a site, then transmitting the recorded information to another site for evaluation at a later time. A brief description of in-home services. In-home therapy usually takes place in a client's home rather than a therapist's office, a clinic. And this is best for those who would otherwise have a difficult time assessing therapies. In-home therapy also refers to situations where counselors travel to conduct the therapies or assessments at the site where the client resides. Let me introduce our group participants. Mindy Fairchild will act as our summarizer for telehealth and illustrator. Stephanie is our summarizer and concluder. I'm Dominique Hale, and I'll be our introducer and also our fielder. Amy Cohn will act as our researcher. The introducer will introduce the debate topics, define the topics, introduce the debate participants in the order of debate. The researcher will state facts found in empirical studies related to the debate topics. The researcher will also state facts found in empirical studies related to the debate topics. The summarizer will summarize the research for both in-home therapies and telehealth therapies, and also give main points of the study's discussion. The fielder will raise topics of discussion through questions related to the summaries of the research. The illustrator will post graphs and data that support these topics. The concluder will give a summary of the debate topics, the pros, the cons, and the discussion. The order of the debate will be the introduction, the research found on telehealth, summarization of telehealth research, illustrations related and field questions related to telehealth, research found on in-home therapy, summarization, illustrations, and field questions related to in-home therapy, and then the conclusion with the research found in telehealth.
Hi, everybody. I'm going to present some of the research we found on telehealth. In our first study, Lindgren et al. In 2016 looked at two things. The first was whether or not functional analysis and functional communication training could be conducted just as well via in-home as it could via telehealth. They also looked at implementing the cost of implementing these procedures for each of the methods. To do this, they looked at data outcomes and costs for implementing functional communication training and functional analysis with 94 children diagnosed with autism spectrum disorder or other developmental disabilities via three methods. The first was in-home, and then there were two types of telehealth. There was in-clinic telehealth and clinic-based telehealth and home-based telehealth. They found they were able to use all three methods to conduct the FAs and FCT, and that as a result of being able to use those methods to via these methods, they were able to reduce problem behavior by 90%. They also found that the cost of implementing these treatments were lower in both telehealth procedures than in-home. They found that the average weekly cost of in-home was nearly $280 per week, while in-clinic telehealth was $220 and in-home telehealth was $160 per week. Mindy has created a graph that will help show us the differences in these costs.
According to what Amy just mentioned with the different prices for the three different methods of implementing, the first screen or the first bar is for in-home, and the next two are for telehealth in clinic and via in-home. So you can see that they're quite substantially different.
So overall, what this study showed us is that these authors not only found that parents could be taught to conduct FAs and functional communication training via telehealth, but that the cost of providing these ABA procedures could be reduced in half by using in-clinic telehealth and by over 2/3 using in-home telehealth. Our next study looked at the cost of implementing an ABA procedure via telehealth and in-home as well, but only the use of functional analysis was considered in this study. This 2013 study, entitled Conducting Functional Analysis of Problem Behavior via Telehealth by Wacker et al., found that the cost of delivering FAs via telehealth to 20 students with ASD were significantly lower if the FAs had been conducted in-home. So the average weekly cost of delivering FAs through telehealth was $57.09 per week, while the cost of doing them in-home was $335.09. Additionally, they found that when using the telehealth model, it took parents and consultants a total of 2.5 hours to conduct an FA, where 1.5 of those 2.5 hours was parent time and 1 hour was consultant time, while in-home took considerably longer, 9.5 hours of time, where 1 hour was parent time and there were 8 hours of consultant time, which you can see on the graph that Mindy has put up here.
This graph actually shows you the drastic difference in time. In the red is consultant time, in the blue is parent time. So with the in-home, it's maybe about half an hour less, but the consultant time is considerably more in comparison to telehealth.
Thanks, Mindy. Yeah, and it was mostly the added consultant time that was needed for the in-home FAs that contributed to the higher cost in this study. Now going on to our third study is yet another study conducted by Wacker et al. In 2013. And in this study, they looked at whether or not telehealth could be used to teach functional communication training to reduce problem behavior. They used the cost figures from the study I just talked about to add a cost comparison component to their research in this study as well. So here they found that when using functional communication training, the problem behavior for 17 children with autism could be reduced by 93.5%. Which you can see there on the bar graph, when telehealth was used. And that this could be done in an average of 21 sessions over the course of 13 weeks. If you compare this to teaching functional communication training in home, they found that they were able to reduce problem behavior as well, slightly more at 94.14%. But with in-home, it took 40 sessions to reduce problem behavior over the course of 56 weeks, as compared to the 13 it took for telehealth, which, as you can see here on the graph Mindy has put up for us. Mindy, did you want to add anything to that?
I just want to, there we go. The considerable amount of difference between the blue bars, which are the telehealth, and the red bars, which are in home, are substantial. I particularly think that the weeks are quite different. So beyond that, no.
Okay, thanks. So basically what we learned from this study is that we can teach families to teach functional communication via telehealth. It was much more advantageous, not necessarily in reducing the problem behavior, but like Mindy said, it took much less time. As I mentioned earlier, this particular study also looked at the cost of delivering functional communication training via in-home and telehealth. They found that the cost of this teaching procedure in telehealth was approximately $11,500 per year, or about $60 per session. And the cost of in-home was much more, at $55,872 per year, or about $291 per visit. Again, Mindy has added a graph for us depicting this difference.
As far as the difference between the two, I mean, there's a considerable amount between telehealth versus in-home. The bar graph on this one is actually sideways due to just so you can actually read the numbers and how they actually compare, but that is quite different.
Thanks, Mindy. So a majority of the added expense in this particular study was due to the amount of drive time for the consultant, an extra 1,100 hours of drive time that the consultant had to do to deliver the functional communication training in-home, as opposed to telehealth. Switching gears now, our remaining studies just looked at supporting telehealth using specific interventions by telehealth. And in the first study entitled Using Telemedicine to Conduct Behavioral Assessments, Barreto et al. In 2006 used telemedicine to conduct brief functional analyses for children with developmental and behavioral disorders. In this study, they found that they could determine the function of disruptive behavior for 2 different children by conducting brief functional analysis using the phone and what they called continuous audio transmission at a remote or an in-home site. Using these technologies, they found that they were able to identify the problem behaviors of the first child, Charlie, were maintained by negative reinforcement in the form of escape from demands, and that Daisy, the second child in the study, that her self-injurious behaviors were escape-based due to difficulty she was having in her physical therapy exercises. So again, Barreto's results show us that an ABA procedure, in this case, brief functional analyses, could be successfully conducted via telehealth as well. So what have we learned so far? We have learned that FAs, brief FAs, and FCT can be conducted successfully via telehealth. But what about discrete trials, something I think a lot of us more commonly use in our day-to-day work? Hay, Hansen, and Eldavik in 2013 studied this. Their paper was entitled Training Discrete Trials, Teaching Skills Using Video Conferencing. In this study, the researchers set out to see if telehealth could be used to train staff to teach matching, receptive labels, and expressive labels. To do this, they assigned 14 participants to 2 different groups. The first group received discrete trial training in-home, and the second group received their discrete trial training via telehealth. 2 months after either the on-site or the video training, they did some follow-up testing on both groups. And what they found was that in both the in-home and telehealth group, staff was able to be trained to implement discrete trial, and they also found that the children in both of these groups were able to learn matching, receptive labels, and expressive labels. So another demonstration that staff, and consequently children, were able to learn just as much via video conferencing as they were via in vivo teaching. So more support that telehealth can be used to successfully serve children with autism and other developmental disabilities with lower time commitments and with lower cost. And with that, I will turn it over to Mindy to kind of summarize the information we found on telehealth.
Thank you, Amy. That was fantastic. She just actually gave you a lot of information to take in about telehealth, so I'm going to try to break it down and just briefly summarize all the information in layman's terms that was just gone over about telehealth. So first off, telehealth is an amazing tool that can help families in need of services for their child. However, it is not always covered by insurance. So this is a matter that families need to look into before enrolling in services to see if the state that they live in is one that insurance covers the cost. That's not saying that families cannot pay for the services out of pocket, but ABA can be quite pricey at times, so something to look into. That being said, telehealth is a fantastic solution for those families who are in need of ABA services, but none are available in their area. For example, if they live in a very rural area or even in a big city that has very few BCBAs that live in the area, telehealth is definitely an option that would be best for those kind of families. Having access to a BCBA using their computer allows them the freedom of no boundaries or obstacles to have to deal with besides the actual internet connection. So this directly links to the core ethical, principle of benefiting others. When families are in need of services, trying to find a way to get them what they need is a part of our responsibility, essentially. So something else that telehealth has shown to do is just basically help the families in the situation that they are actually in. But it doesn't have to stop there. Besides benefiting others, telehealth also touches on ethic principles of being just, because not every family who needs ABA can afford it, and trying to find ways to cut families a break, for lack of a better term, one being the cost of services, is a way to get them what they need in a way that they can get it. And providing that way is appreciated, obviously, by them. You're giving them a helping hand, essentially. Parents are a key factor in telehealth. You can't do it without the parents because they become the therapists. And it can be both a role that's accepted with authority and giving them confidence. Parents can, they get to conduct their own assessments and their FCTs and the initial behavioral assessments to really understand what's going on with their child. But this is more convenient for the parents due to it being right in their home. Plus, they are able to see the results for themselves. But some issues also arise on how reliable their observations and data are, since they are technically not trained professionals. They haven't had their RBT training or things like that. So it can fall under some subjectivity at times, which can be an issue when it comes to what programming and whatnot. This hits on the Ethical Compliance Code of 1.04, which reviews the points connected to integrity. So now, that being said, some parents are able to get specialized DTT training according to Amy's research, which can be most beneficial in improving their skills on utilizing ABA in their telehealth. But BCBAs need to be cautious of burnout. Signs in parents and caregivers implementing an ABA program through telehealth. The program is sustained by the parents, and the parents almost alone. They're the therapists, they're the parents. So burnout can happen because they don't know what they're doing. They're trying to figure it out. They have to be a parent, they have to be a therapist, and that can just lead to a lot of stress for the therapist, for them as a person. So if pushed too hard or too much is expected of them, along with all their other responsibilities, it's not uncommon to wear them out. One of the last things that I want to explain when it comes to using the telehealth model is the confidentiality risk it poses. Using anything electronic in this day and age comes with risks of hacking and people finding information that's supposed to be secure, but it wasn't as secure as it was supposed to be. And so that call goes under HIPAA and all other kinds of can of worms. So making sure the internet connection that's being used for the telehealth through the computer is secure. So confidentiality is a big issue and needs to be protected, and which says must be a priority according to the codes, the ethical codes of 2.06 and 2.07. So with that, I'm going to turn it over to Dominic as our fielder.
Thank you. Thank you, Mindy. Under what conditions should telemedicine be considered? Should certain higher or lower intensity behaviors be considered primarily for in-home consultation?
I'll take that one. So we have the Barletta study. The results of that study lead us to believe that even severe behaviors can have successful consultations using telehealth. In that study, a particular set of participants were both considered to have severe high-frequency behaviors, and consultations via telehealth actually decreased their behaviors.
Okay. So with considering family characteristics and training types of consultations and therapies, bringing services to rural communities come with factors that should be considered, such as economic background and family resources, which may not support the need of Wi-Fi and computers and laptops and cameras and things like that. if insurance is not covering these services and these the equipment needed to support this type of therapy, who is covering the cost of the equipment needed for these services and for people in rural areas or those who don't have the economic means to buy it?
Sure, I understand that. So services provided through state funding that are actually state funded and private funding, like with insurances, usually cover the cost of equipment needed for this population to provide those services that they are actually requiring. So as stated in Barreto's study, again, referring back to that one from the previous answer I gave you, they were able to contract equipment through the State Department of Education. So Amy answered about state resources, and that kind of feeds along that line as well. Any more questions?
Okay, thank you. Yeah, I have one more question.
Okay.
The BACB Code of Ethics in section 2.09, section B, states that the behavior analysts have the responsibility to advocate for the appropriate amount and level of service provision and oversight required to meet the defined behavior change program goals. A parent or guardian who's implementing the protocols and treatments without as someone in home doing oversight and doing proper training, how would proper training be given to individuals such as parents who are implementing these protocols?
Sure. Good question. So just as supervision happens with in-home therapists who are contracted by BCBA, supervision would be provided for parents very similarly, maybe more on a weekly or bi-weekly basis. But the Code of Ethics is upheld by providing oversight through telecommunication and streaming video rather than in physical presence. So they basically replace each other. A BCBA might come to an in-home and supervise the therapist. This way, they're giving direct supervision, but with telehealth, they're just doing it through a computer instead.
Oh, thank you, Mindy.
Sure.
Now, we'll bring in in-home. So Amy, could you give us some research on in-home?
Sure. So what we've learned from the research I presented a little bit earlier, as well as Mindy's summarization of telehealth, is that telehealth is useful and it's good. It can be used to teach a variety of different ABA procedures at more quickly and at a lower cost than in-home. However, the use of ABA via telehealth is not something insurance companies have fully embraced yet. In an article entitled State of Telehealth in the New England Journal of Medicine, Dorsey and Topple in 2016 noted that only 29 of 50 states require private insurance to cover medical telehealth, not necessarily telehealth related to ABA, but medical telehealth. That's double from what it was 3 years ago, but still less than the 44 states which require insurance coverage for in-home ABA, as you can see on the map that Mindy has put up for us. Mindy, did you want to comment on the map at all?
Just briefly, just so that they can actually see. The red states are the ones that basically don't cover. The blue states are states that actually cover to some degree. It might not be full coverage, but they're at least offering some coverage.
Okay, and I think with the addition of Medicaid and the Affordable Care Act plans, I would anticipate that that map should be nearly entirely blue at this point. So we can see that in-home ABA is covered and covered pretty well, unlike telehealth ABA. So we really need to look at then what research supports in-home ABA. And I think the first study that comes to mind for me when I think of in-home ABA is Dr. Lovas's 1987 landmark study. In this study, he looked at whether or not differing hours of in-home ABA could improve the intellectual functioning of children with autism. In his study, he found that 47% of children who received an average of 40 hours a week of in-home ABA could achieve normal functioning, where normal functioning meant that these children could attend regular education classes with no assistance. This, of course, is the outcome every parent hopes for, right? Unlike ABA via telehealth, which is a relatively recent methodology, we have known for many years, as far back as 1987, that in-home ABA works for children with autism, that it's critical for children with autism to receive these services. Some of the other studies I looked at, so we know in-home for kids with autism is beneficial, but what about how in-home affects parents and siblings of children with autism or other developmental disabilities? In 2009, an article entitled Parents' Experiences of Home-Based Applied Behavioral Analysis Programs for Young Children with Autism, Grindle et al. Surveyed 53 families whose children had received intensive in-home therapy in an attempt to better understand the impact this particular methodology had on their lives. In general, they found that parents were really positive about in-home therapy. They reported the additional support in the home was helpful in terms of managing behaviors, feeding, toileting, and that it allowed them time to complete household chores and connect with people outside of the home, their friends, maybe they went and met for coffee, as well as the therapists who came into their homes to provide those services. Additionally, parents felt that they were able to learn how to use a variety of effective behavioral techniques simply by observing the staff who came into their home to help. The study also reported on the benefits of in-home intensive behavioral therapy to siblings. And in the study, they found parents reported siblings enjoyed involvement in therapy sessions, that siblings were able to learn about autism and about ABA by watching treatment sessions, and that according to Sabula in 2012, there were increased positive interactions between siblings and the child with ASD, as well as a decrease in negative interactions. So Mindy put together a really cute visual for us, kind of outlining these studies, which she has up. Mindy, did you want to add to that at all?
Okay, there we go. Sorry, Amy. This is just a document that shows that everything that you basically just mentioned about the parents, the points that they mentioned that were positive about the experience they had, as well as the siblings down below about how they interacted with their sibling with autism.
Okay, thanks, Mindy. So looking at this chart, these are all great benefits of in-home ABA, right? I think each and every one of us would say that every single one of these points is important, but difficult to attain through the use of telehealth. I have one more study supporting the use of in-home ABA. And that study was done by Weiner and Ingersoll in 2013. They furthered the argument for in-home over telehealth when their study found that 1/3 of participants who received self-directed training programs via telehealth ended up requiring additional training to fully achieve fidelity in the implementation of ABA. They also found that on-the-job coaching, feedback, and problem solving was really critical in maximizing the effectiveness of ABA training programs. So that kind of sums up some of the research we found on in-home. And so with that, I'm going to send it over to Stephanie to summarize that information. Stephanie?
Thanks, Amy. Well, Amy just gave you a lot of great information about in-home therapy. It's without question that without insurance, in-home therapy can cost a lot. And the options that are available to parents can be highly limited depending on where in the United States they are living. With in-home being an insurance accepted therapy, it definitely helps the financial strain. Unfortunately, with With insurance dictating supervision, it can leave therapists and the parents without adequate feedback on the goals. So sometimes the goals aren't updated as regularly as they should be, and therapists get a little bored or can't continue to provide the reinforcement needed. On the upside, the relationship between the parent and the child does increase. With a therapist in the home, they get to kind of take a break and sit back and watch somebody else work with their child and benefit their child. Amy also mentioned a great thing for siblings is siblings get to be part of the therapy sometimes. The siblings do get a chance to be a part of it and learn and have the involvement of the therapist, increasing their chances of communication with their siblings. Parents also report that even with a high turnover rate of therapists, the benefit is still stronger. Having somebody in their home still feels better than having to provide it themselves. The pressure's a little off for them. I'm going to turn this over to Dominique for questions regarding in-home therapy.
Thank you, Stephanie. What are the effects of providing therapy on parents and therapists?
Oh, that's a great
in-home.
That's a great question, Dominique. So Hurt et al. Conducted a survey given to parents and therapists. Burnout was a big topic discussed. Parent burnout from being the continual caregiver and then also giving the therapy was a big concern for them. And then he also discussed that therapists burn out from the lack of having supervision or little reinforcement or motivation to continue.
Okay, thank you, Stephanie. One more question. There are many insurances in states that are requiring insurance to cover ABA therapy and in-home therapy, but wait lists are extensive. What other options do families who need therapy have?
Telehealth does give parents an affordable option for services. Parent training could also help relieve the need for in-home until affordable services are available to them.
Oh, thank you, Stephanie. Well, and now, Stephanie, with the conclusion.
Yes. So in conclusion, we heard a lot of information. We discussed that for in-home, it's widely accepted by insurance. That's huge. Parents do get a financial break by being able to access their insurance. They also are benefiting from on-site training. They get to learn from the therapist that they have in their home, and they receive immediate feedback. They get to see if they need help, the therapist is right there to help with corrective measures or encouragement. We also did learn that without insurance, it's really costly and parents are unlikely to be able to afford it out of pocket. There's also insurance doesn't allow for adequate supervision at all times, which does leave therapists without the adequate feedback that they need to continue to provide services to the client. For telehealth, parents, it was shown that parents can learn how to provide FCT training to their children effectively through the guidance of their BCBA on their computer. It's highly accessible when otherwise no services are available to them. There's a breach of confidentiality when we're using technology. So without a secure line or ensuring a secure line, you don't know if somebody's able to listen in or is getting information from you. And the parent caregiver burnout is more than likely going to happen. Having the parents provide, to be a mom and a dad and then also provide the therapy can cause strain on the relationship between them and their child. I'm also going to discuss the many ethics codes that we need to be aware of when providing services to the families, whether it's in-home or in telehealth. Code 1.06 discuss multiple relationships. Well, within home, there's obviously a risk of a dual relationship forming. That's pretty easy, and it happens sometimes without you even realizing it. Telehealth, they could ask you for favors on facilitating an internet connection, or maybe they need extra help and can't pay for it. So you need to be aware of the risk. 2.01 talks about accepting clients. The BCBA needs to have training and understanding of what the client's needs are. So whether they're going to facilitate in-home or telehealth, they need to know that they can do it effectively and that they've had the training to do it. 2.03 talks about consultation. They need to consider the limitations of telehealth. You can't always see the whole picture on the screen, and you may not be able to see some of the environmental factors that may be affecting the client. So the BCBA definitely needs to take into consideration the limitations that happen with telehealth. 2.06 discusses maintaining confidentiality. Confidentiality for in-home is when you're transporting your client info in your vehicle. You need to have it locked up. You need to make sure that you can get it to a safe place where somebody else isn't going to be able to access your client's information. As we discussed earlier with telehealth, your connection may not be secure when you're providing services, and you may not be able to see who else is around listening in on your conversation. Lastly, I'm going to talk about 2.09. It's the treatment and intervention efficacy. The BCBA needs to consider who is implementing that plan. The parents may not be adequately trained to facilitate the interventions, or maybe you have a new RBT who's unfamiliar with some of it, or whatever the case may be. The BCBA needs to keep in mind who's implementing that plan and how well trained they are or may not be. This concludes our debate on in-home versus telehealth services. I want to thank Amy for discussing our research, Mindy for our illustrations and summary, and Dominique for getting us started and asking questions. Thank you for listening.